In this session we'll discuss pathogenesis of diabetic retinopathy. The characteristic pathological changes in diabetic retinopathy are parasite loss due to abnormal parasitic deposition of material due to sorbitol or advanced glycation end products through the aldose reductase polyol pathway. Basement membrane changes. Retinal capillary endothelium is covered by a basement membrane, which is normally approximately 0.5 micro thick. In diabetic retinopathy, there is an increase in the thickness of these layers. This thickening may be as much as 5 folds, which results in impairment of diffusion and transfer of nutrients and metabolites. Neovascularization occurs. When a focal area loses its perfusion, the retina suffers ischemia. In response to ischemia changes the retina, retinal vessels or RPE cells secrete some vasoproliferative factors, which are thought to induce neovascularization. Some of these vasoproliferative factors are vascular endothelial growth factor, platelet-derived growth factor and hepatocyte growth factor. Especially VEGF-A, which inhibits the growth of retinal endothelial cells, are implicated to induce neovascularization. Clinical signs of diabetic retinopathy are microaneurysms are the first ophthalmoscopically detectable signs of diabetic retinopathy. Microaneurysm is a microvascular abnormality which is characteristic but not pathognomonic of diabetic retinopathy. Mechanism of formation of microaneurysms are parasite loss causing local weakening, alteration of the capillary basement membrane, the unrestricted proliferation of the vascular endothelial cells. Appears as small red dots with smooth borders and sharp edge. In fundus fluorescence angiography they appear as tiny hyperfluorescent dots, typically more numerous than visible clinically, and remain hyperfluorescent without any change in size. And hemorrhages appear as black spots due to blocked fluorescence. Microaneurysms are usually 12 to 100 micrometers in size. Those greater than 30 micrometers are visible ophthalmoscopically. They are not to be larger than 125 micrometers. Whereas hemorrhages are usually larger than 125 micrometers. Retinal hemorrhages can be superficial or deep hemorrhage. Superficial hemorrhages located in nerve fiber layer. It is feathery or flame-shaped because of the tighter organization of the cells and limited extracellular space leads the blood to follow the configuration of the axons. Deep hemorrhages are located in the outer plexiform layer or the inner nuclear layer. They are blot-shaped or dot and blot-shaped because of the compact middle layers of the retina. Hard exudates are a yellowish, well-circumscribed accumulation, deep to the retinal vessels in the outer plexiform nerve fiber layer. They are formed by the deposition of lipid and lipoproteins and are the sign of abnormal vascular permeability. Although hard exudates can be found anywhere in the retina, they have a predilection to congregate in the macula. Patient may have moderate to severe loss of visual loss if the fovea is involved. Hard exudates occur in two types of retinal distribution, the circinate pattern and macular start. Circinate pattern appears as a complete or partial circle separated from the leaking vessels by a clear zone. Macular star occurs due to lipid accumulating the fine layer of Henle's layer surrounding the macula, which has been discussed in the macular anatomy video. Cotton wool spots are soft exudates or cystoid bodies or nerve infarcts. Lie in the nerve fiber layers of the retina. represents ophthalmoscopic appearance of a microinfarct. Their presence implies ischemic microvascular disease. Appear initially as white fluffy patches. Most commonly in the posterior pole, retinal nerve fiber layer is the thickest, become smaller and more circumscribed with time, absorbing completely after 6 to 8 weeks. Venous loops, venous beading are indicative of extensive ischemia of the retina and manifest as saccular bulges in the wall of the vein. Seen frequently adjacent to areas of nonperfusion. Reflects increasing retinal ischemia, most significant predictor of progression to proliferative diabetic retinopathy. Next, coming to intraretinal microvascular abnormalities, also known as IRMA. Microvascular dilatation is often found near areas of capillary obliteration and is called intraretinal microvascular abnormalities. IRMAs are shunts that run within the retina from arterioles to venules. Often found on the borders of the nonperfused retina. Appears as fine, irregular, intraretinal vessels that run from arterioles to venules without crossing major blood vessels. FFA shows focal hyperfluorescence associated with adjacent capillary dropout areas, but they don't leak. To summarize, layers of retina affected in diabetic retinopathy are: cotton wool spots in nerve fiber layer, microneurysms in inner nuclear layer, dot blot hemorrhage in inner nuclear and outer plexiform layer, flame-shaped hemorrhages in nerve fiber layer, hard exudates, outer plexiform layer.